So after 12 years, we have this opportunity to host this APO and along with AOS. Like to thank the organizers for giving us an opportunity to share our experiences is in one of the very important topic related to retina. So, so I request Dr. Karthik to come and join me to chair the instruction course. Also, I'd like to welcome my co-authors, Dr. Namit, Dr. Sripati, Dr. Saurabh, and Apurva will be joining us. He is in another session. And also we have a couple of potential audience who has joined us. So I'd like to welcome them also. As you all know, diabetes is one of the common diseases which we encounter in our day-to-day practice, and India is considered as a diabetic capital. And diabetic retinopathy is one of the common diseases which we see. Amongst that, the main cause of visual loss is macular edema. It constitutes around 40% of the visual loss in diabetic retinopathy, out of which, as per the literature, the 7% constitutes about recalcitrant. Okay, so we would like to.
I think we will start off the session. So we'll start with the first topic, which is the recalcitrant and refractive DME by Dr. Manjunath Bhaskar Anand Kumar.
Good morning, everyone. So the topic is recalcitrant diabetic macular edema. So there are certain things, words which in medicine which we need to change it. So something like pyrexia of unknown origin. So I think those words were designed initially when there were no much improvement in investigations or technology. Now one such word, what I believe is recalcitrant. So what I feel is more appropriate is non-responders. So if we carefully evaluate and find the reasons, we can definitely find out what is the reason why the patients are not responding to the macular edema. So myself, Dr. Manjunath B.A., I'm working as a consultant at M.M. Joshi Ganesh Netralaya Eye Hospital, Shirsi, Karnataka. So what do you mean by recalcitrant? Recalcitrant is something like who is not responding. So disobedient. So this is going to be a presentation layout. So as per the definition, a DME refractory patient is the one who did not achieve complete resolution of the disease regardless of the treatment administration. Based on the OCT, so after this, even after the 6 months of continuous treatment, if your central foveal thickness is more than 250 microns associated with the visual loss, this is considered as a refractory or persistent diabetic macular edema. As per the DRCR.NET protocol, it has showed that more than 40% of the patients who are treated with ranibizumab did not achieve the complete resolution of macular edema. So the few good things which happened in these days is we understood the disease better, better technologies are available to visualize the DME, and we have more treatment options. So bad thing is sometimes in spite of all this, our treatment doesn't work and the edema remains refractory. So the treatment of DME is like a roller coaster drive actually. It's more like an emotional roller coaster drive. The videos are not playing. So whenever there is an increase in edema, we tend to treat. Whenever there is a decrease in edema, we tend to observe. This is more like an emotional roller coaster drive for a patient as well as a doctor. So this is the overlay of DME management. What are the options which are available? We have various anti-VEGFs, we have steroids, we have laser photocoagulation, and the surgery. These are the various options which are there in our portfolio. So this is a pathogenesis of DME which we are very much aware. So hyperglycemia leads to increase the free radical activity that results in the osmotic damage and ultimately capillary epithelial damage. So we need to know what is the reason behind these recalcitrants. So we need to find out various causes like what are the associated tractional elements in form of VMTs or epimacular traction. This has come to use after the having the some of the advanced investigative modalities like SD-OCT, FA, and wide field fluorescein angiography. So what are the point you consider whenever you are treating a DME is like as a routine in any other DMEs is the baseline visual acuity, the duration, ocular environment as the local factors, other any VMT or ERMs or any systemic factors. The main goal is to find a management pathway that will maximize the success and minimize the failure. So these are the various advances which took place in DME. So coming to systemic control, which is very much important, it's easy to remember in ABC. A stands for your HbA1c, anemia, 24-hour microalbuminemia. B for your blood pressure control. C for your creatinine and control of cholesterol. So this is what I have designed, like DME in treatment. You should ask your patients to be follow this DME, like they should follow the diet, discipline, they should trust the doctor, medication, meditation, and they should be motivated properly, and ask them for exercise as well as education. So various options in brief we have for treating, especially in refractory DMEs. So switching of anti-VEGFs. So all these topics will be covered in detail to other co-authors. So the rationale between the anti-VEGF is like there is a molecular difference between the molecules and the pharmacological targets of these agents. So corticosteroids, as we know, inflammation acts as a protagonist in DME. Inflammation occurs before the edema. DME may shift from primarily VEGF mediated in acute phase to the inflammatory in chronic phase. So whenever you treat with steroids, it will stabilize the blood-retinal barrier by downregulating the expression of VEGFs, inhibiting the production of prostaglandins and expression of inflammatory cytokines. So of course, lasers have been largely replaced, especially the focal lasers have been largely replaced by the anti-VEGFs. We no longer do focal lasers in foveal edema. Only in some cases like non-foveal edema, we try to treat them with focal lasers. So what is the role of PRP in diabetic macular edema? There have been some studies like DAVE studies which has been conducted, especially the targeted retinal photocoagulation in DMEs. Even in that, they have found that there is no much useful when they do only the targeted laser photocoagulation without using anti-VEGFs. So the new molecules which are there in our portfolio like brolucizumab. Brolucizumab is a very unique and small molecule, is known for better penetration, and it inhibits the larger VEGF molecules. So it has been found that it has 12 folds higher molecular dose than aflibercept in the same volume. So it binds with high affinity to all anti-VEGFs. So it has been found much more efficacy in compared to other molecules. They respond better in cases of recalcitrant DMEs. So there are two important studies which have been done, like Castrol and Kite. So in that they have found that there is a superior reduction achieved with brolucizumab of 6 milligram compared to aflibercept 2 milligrams. So one more molecules which recently we are using is faricimab. Is the first intravitreal bi-specific monoclonal antibody. It inhibits both your angiopoietin 2 as well as VEGF-A. So it has been found that faricimab may extend the treatment interval for the patients with DME which are refractory to aflibercept as well as ranibizumab. So definitely there is a role for combination therapy, though helps in treatment of recalcitrant edema. It helps in extensive control of multiple the complex pathways which are involved in recalcitrant edemas. So whenever there is a taut highlight, you need to remove it, whether it's in the form of anterior-posterior as well as a tangential traction. You need to carefully look for it in the imaging, and you have to remove it surgically. So how does the surgery help? Surgery, helps in relieve the tractions in all the directions, and also relieves the vitreoxysis. So vitrectomy increases the oxygenation in the vitreous cavity up to 10 times. So PRP at the time of vitrectomy also helps in reducing the mid-peripheral ischemia. So these are the small videos, not playing actually. Routinely what we do is just do a core vitrectomy, induce the posterior highlight, stay in the ILM with brilliant blue, and you remove it as in routinely and in all other ILMs. The only thing you need to remember is the removing the ILM is not that easy as you remove it in macular holes. The ILMs are quite sticky, so you need it will come like in a piecemeal. So these are a few images just to show the pre and post how the removing the tractional elements will help in responding to the treatment. Even what we have found is after removing this traction, even with anti-VEGFs or any other molecule which we used to use previously, they respond better after removing the tractions. So newer frontiers like ROCK inhibitors, neuroprotective agent, mTOR inhibitors are in the pipeline. So at present, the standard of care is definitely a combination therapy. Sustained release devices and micropulse lasers are interesting and potentially promising. The holy grail would be method to improve or reverse the macular ischemia. Macular lasers is no longer a gold standard for treatment. So posterior highlight management is vital for treatment of a chronic condition. So tailored approach based on the genetic profile could be a future. So 1/3 are non-responders or recalcitrant. Good metabolic control improves the outcome in all the DMEs. Recalcitrant DME requires alternate therapy with steroids or prolonged monthly anti-VEGFs. Vitreous surgery is required in tractional DME. So with this, I think you can make your DME obedient for your treatment. Thank you.
Thank you very much, Dr. Manjunath. Meanwhile, I can ask Dr. Saurabh to start. Yeah, so that was a very interesting presentation.
Yes, sir.
I want to know. Excuse me. I want to know when should we decide this DM is untreatable, means we should not continue the treatment further.
No, that's what I told. Like there is nothing called like non-treatable or non-responders.
Yeah.
So you need to carefully identify what is the factors which is leading for the patient to not respond.
Yeah.
So down the line you will understand. So there are other co-authors who will be telling us how to identify the factors which are really making those DME recalcitrant.
Yeah.
So once you carefully identify, starting from your systemic factors to other local factors, like I told, like these tractional elements. Even the smallest of the small tractions which need to be identified with a careful investigation. Once you remove those tractions, definitely these patients will start to respond.
If there is no traction and all the macula, central macula is studied with hard exudates, so is there a point in treating further?
No, once that's what. Look at the visual potential and the systemic
like
factors.
I will be answering those
Yeah.
things in my slides so that you will have a now how will an OCT image create an impact on the treatment is what I will answer. So and after that we can have a re-evaluation of those. So a very warm good morning to you all, especially Sangeeta madam and Veena. Thanks. Pleasure to have you here. So, like at the outset, I thank Dr. Manjunath for providing me an opportunity at this auspicious event as such. So, I will be speaking about role of biomarkers in diabetic macular edema. So what's a biomarker? It is a happening in a cell now that we want to find out and to know what and to predict how is the future. So why are we using this in a patient with a macular edema? So because the treatment is getting expensive, invasive, repetitive, and the improvement in the visual acuity has been a challenge. So how it's going to help? It's going to guide us to know the outcome and to prognosticate to an extent and to choose a wiser drug, might be an anti-VEGF or a steroid, and to decide when to switch in between them and to correlate the visual acuity with the OCT image. So in the meantime, we have had so many types of biomarkers that are general, ocular, and others. So like in general, it's age, type of diabetes, how recalcitrant itself it is, how poorly it is maintained, how well it is maintained, a family history, hypertension, and the ocular ones, the most important is the visual acuity of the presentation. The better the visual acuity, the better is the improvement that we see. The location of the microaneurysms, the cortical spots are the telltale signs of the future ischemia and the present like ischemia. The location of the hard exudates, if they are located at the fovea and if they are in a clump, you might not treat them as such. So in specific, I will be speaking about the imaging biomarkers. Since quite a time, since a decade, we have been talking about only two things, that is the central macular thickness. And the protocol A told us that even if the maculas are thick, the visual acuity can be good. So you cannot say that if the macula is thin, the visual acuity is fine or good. So it is a modest correlation in between the visual acuity and the central macular thickness. The protocol T, after so many years, the protocol, like after protocol A, it also told that it's not an accurate predictor for the visual acuity. So we need more biomarkers. It is not that central macular thickness cannot be considered more important. Now, what are those? To start with, we have disorganization of the retinal inner layers. So it is a lack of definition of the boundaries in between the ganglion, the plexiform, and the inner outer plexiform layers. So there is this. The diffuseness that you see here is the drill. So why is drill important? And because there is a lesser response to the anti-VEGF. So once you find a drill which is more than 100 microns at the fovea, and it is said that it's going to drop the visual acuity by minimum 6 ETDRS letters. So drill is a very important indicator now that we see that it is going to predict the likelihood of improvement or decline. We see drill in different phases of treatment. Now, I am going to share a patient who received an injection of Pegenex. So, bortezomib was injected looking at the quantum of the macular edema, and you see that we noted a drill. In spite of noting this diffuseness in the inner layers, we still proceeded with the second dose of drill, the Pegenex, and we saw that there was hardly any response after 2 months of time. Now you see here we have injected on 20th of November, and on 27th of January, we still see that the macular edema is as the same. So it means that, yes, drill should have been taken a priority while we saw the OCT scan. It's not that now these drugs act like all the time. The second most important is the hyperreflective foci. These are not hard exudates. To define, these are the intraretinal hyperreflective dots on the OCT scan, which with the macular edema, they represent microglial cells which are enlarged, and few people hypothesize that they are the subclinical lipoproteins that extravasate after the breakdown of the inner blood retinal area. How to say that it is not a hard exudates. We don't see them clinically. It is very difficult to point them, and they are lesser than 30 microns. They have no back shadowing as such, and the reflectivity is marginally more than the retinal fiber layer. So you see, these are the hyperreflective foci, and so these hyperreflective foci are again a telltale sign of significant breakdown of blood retinal barrier, and usually the response is much better with steroids. So with time, these hyperreflective foci, if there is no treatment or if there is a delay in the treatment, they migrate deep. So they go into the deeper layers and then the choroid. Now, once they enter the choroidal layers, the prognosis is significantly bad, and they are responsible for reducing the capacity of the outer layers, that is the EZ, the retinal pigment epithelium, and hence the treatment will be usually ineffective if you see a hyperreflective choroidal foci. The DORL, the disorganization of the outer retinal layers, the ELM, the ellipsoid zone are the most important, and they contribute to the outer blood retinal barrier. So whenever you see any damage to these, it is considered as a chronic edema. I have got two images now. One is A and one is B. Now you see that in this image of AV, there is a total obliteration of ELM, the ellipsoid zone, and the pigment epithelium. But in the image B, we still have ELM intact and the ellipsoid zones intact. So what I mean is, so if we get how to prognosticate is, if we want to tell the patient that you have marginal chances of improvement, it is the patient B. Now these both are chronic macular edemas who have not received any treatment since years. So now this will give you pinpoint points to inform that we should treat or we should just wait and watch. Like intraretinal cysts. Since I had my thesis in diabetic macular edema, and we had like only two things, that is a subfoveal fluid as well as CMT. So these were the two markers. But now if I do my thesis again, it will be so many points that I have to note. Now intraretinal cysts, the location of cysts is very important. The outer nuclear layer is where the cysts like originate, and as they enlarge, they engulf the ganglion cell layers. And once we see that if they are involving the ganglion cell layers, you see that the macular edema starts to be chronic. So the location of the cysts are important. The size of cysts is important and should be important point to correlate with the visual acuity. So as the cysts persist and the bridging processes that you see, there are so many bridging processes here. There are these junctions that connect the inner and the outer layers, and these the cysts coalesce and there is loss of junctions. Once these junctions are lost, this is a telltale sign of chronicity. Now these bridging processes are contributed by the Muller and the bipolar cells. Now, as with time, with treatment or without treatment, there you see some atrophy or the foveal thinning. This is again an important sign that this macular edema is chronic and their outcomes with the treatment will not be great. Now you see in this scan, you see there are so many bridging processes which might have been there are all lost. So like I was just talking about a subfoveal fluid, and it itself is an important indicator of a systemic control. Now you see in one patient with a right eye, I have a drill, and in the other eye, I have a subfoveal fluid. So these both can coexist at a time. And many studies suggest, few say that the steroids work, the implant works, and few say that the aflibercept works. So again, to finish, foveal aversion sign, this is very important. These indicate that the treatment will be prolonged. The improvement will take a significant time. The retinal capillary microaneurysms can coexist in patients with hypertension also, and are very important sign of leakage, should be treated with laser and will need more and more injection. Hyaloid, Manjunath had already spoken about it. So the newer thing is choroidal vascularity, the index, where people have started to measure the choroidal thickness and then plan the treatment. So to end, now there are so many things that we have to see on a scan, and we have to be patient while we look at the images. Thank you.
Thank you, Saurabh. That was quite a lucid presentation. Might be if you present the same topic by next year, you will have a few more biomarkers to add. So when we started our post-graduation, we hardly had, based on the OCT, we had whether it's a spongy edema, treat with anti-VEGF. If it's a cystoid macular edema, you treat with steroids. As rightly mentioned, if there is a subfold detachment, send it to the physician for him to ask him for a good glycemic control. So over the period, we have evolved and we have drill, and now the mechanism has started from retina and moving towards the choroid. So, so we need to look into deeper aspects. So, thank you. So, may now invite Dr. Namit to present his talk on does switching really helps in switching off the diabetic macular edema. Over to you, Namit.
Good morning, everybody. Thank you, Dr. Manjunath, for giving me this opportunity. So does switching really switch off DME? So as we all know, anti-VEGF are widely accepted as the gold standard treatment for center-involving macular edema, and the efficacies have been proved by multiple randomized controlled trials. But a large percentage of patients, they show very poor response to anti-VEGF in spite of being given for a long period of time. Protocol T showed us that approximately half the cases treated with bevacizumab did not respond and had persistent macular edema even at 2 years. Protocol I showed us that CFT never came below 200 microns with ranibizumab. Half of them failed to achieve more than or equal to 2-line improvement, and 40% had persistent macular edema even after 6 months. So why do anti-VEGF fail to work? So at this juncture, I would like to talk about two types of functional responders to anti-VEGF. One is the early responders, which exhibit visual gains of more than or equal to 5 letters from baseline at 3 months. Another set are late responders, which have visual gains of more than or equal to 5 letters from the baseline at 6 months only. So the late responders could be mistaken to be non-responders. If anti-VEGF are switched too early, they can be missed. So non-responders can be functional non-responders or anatomical non-responders. It is very interesting to know that 1/3 of the patients on anti-VEGF treatment are functional and anatomical non-responders. So the exact reason for non-response is not clear. However, tachyphylaxis has been thought to be responsible because of continued drug injections and repeated drug injections. Tolerance, underdosing, sometimes the patient does not come when he is advised to come for treatment. So underdosing and non-response occurs that time. So the other causes of non-response are that anti-VEGF are not effective in all patients. It does not suppress all inflammatory cytokines, chemokines, and in these patients, anti-VEGF just doesn't work, and steroids switch is definitely required. So why to switch? Why do we need to switch? Just giving continuous anti-VEGF treatment doesn't mean that the DME has to respond, which was showed by the protocol I or restore studies, which showed that repeated injection of anti-VEGF did not ensure successful outcomes. And in RISE and RIGHT trials, the patients were identified who were likely not to achieve optimal outcomes from continuation of anti-VEGF, and these patients, when they were switched to a different class of drugs, they did fared better. So when do we switch? There is no uniform criteria to switch. However, two things to be seen is that of the central macular thickness and visual acuity. So 3 different studies have gone through, and 3 different studies have 3 different criteria. So one criteria which was looked at was less than 20% CMT reduction post 3 monthly injections. That was the time to switch. Central macular thickness of more than or equal to 10%, it was time to switch, or less than 50%, half of the reduction in excess of macular thickness, 3 to 4 months even after 3 to 4 monthly injection, it was time to switch. Coming to the visual criteria, some studies said that visual gain of less than or equal to 5 letters, it was time to switch. Visual loss of more than or equal to 5 letters, and BCVA not improving to more than or 20 or equal to 20 by 40, even in spite of 3 to 6 monthly injections, then it was time for a switch. So when do we switch? Protocol I showed us that the 3-month interval as a potential time for switching. Early switching is recommended before permanent structural damage has happened. So switch to what is the ultimate question? Multiple studies were done showing the efficacies of various anti-VEGF agents. RISE, RIDE, VIVID, VISTA studies, Sula et al., Lim et al. Multiple studies were done, and many of them, two of them from that showed us that ranibizumab fared better than bevacizumab. Two of the other studies showed that aflibercept was fared better than ranibizumab. However, at the end result, although the edema came down, there was no visual improvement that was seen. That means that by the time the chronic diabetic edema was diagnosed and the treatment was continued and anti-VEGF was switched, the visual potential had been limited to some degree. So that's why an early swift action is what we should aim for. So what was the ultimate switch? In between the bevacizumab, ranibizumab, and aflibercept, aflibercept definitely had a higher visual gain, especially in the eyes with worse visual acuity at the time of presentation. Now coming to the new kid on the block, that is the brolizumab, which was done. The study was done, which was called the Brader study. That was an Indian study which compared brolizumab with aflibercept for recalcitrant diabetic macular edema. It showed that at the end of 2 weeks, there was no visual improvement. In eyes either treated with brolizumab or aflibercept. However, 3/4 of the eyes treated with brolizumab, they attained full macular dryness compared to half of the eyes treated with aflibercept, showing that brolizumab switch has an edge over the aflibercept in recalcitrant edema. So the search for the ultimate switch, there has been a shift currently in the classification from non-chronic diabetic macular edema, which is VEGF-driven, to a chronic diabetic macular edema, which is not VEGF-driven. The current recommendation is that switching to steroids at the right time rather than switching anti-VEGF has shown better results by multiple studies. Bush et al. Showed us that early and late eye switch to dexamethasone implant demonstrated improvements in visual acuity and macular thickness greater than those seen in anti-VEGF monotherapy group. This is a chart showing a meta-analysis of a huge study comparing two huge groups of anti-VEGF group and a dexamethasone group. You can see here that there are huge jumps in vision that was seen in the dexamethasone group. It required less number of injection and less follow-ups. So definitely there is evidence to show that dexamethasone has been a better switch. So finally, in conclusion, the concept of one size fits all may not work. Every diabetic is different. Every anti-VEGF works differently. Every eye is different. In my clinical practice, I start off with ranibizumab or aflibercept initially for 3 or 4 months continuously, and then if it doesn't respond or if there is no response that is adequately seen, I switch to either dexamethasone implant or brolizumab, and then continue with the treatment. So switching at the right time, not early, not late, is very important. So not just check visual acuity, OCT, and inject, but also see visual acuity, OCT, and CME trends over the last 3 months, and then only inject, thus preventing conversion to a chronic diabetic macular edema. Thank you very much.
Thank you, Nomit.
Thanks.
You do a visual acuity assessment or you do it after 2 months or 3 months after the anti-VEGF injections?
After anti-VEGF, at least 1 month I wait for the response. And then I check. Yeah.
What will you answer to the patient if the patient is not improving? Like, do you see that we will see one more drug response? It is very tough.
At least we have to wait for it. See, DME is a chronic disease. We can't promise him instant gratification. It's not possible. We have to wait for at least 4 to 6 months minimum to see any response of any drug. So patience is the key, and this is a long-term treatment. I always advise them it is a long-term treatment. There is no shortcuts to this. Switch is definitely later on, when these things don't work, the normal drugs don't work, definitely we have to switch. But at least trying for 4 or 5 months.
Especially with ranibizumab, I see that if it is not working at 1 month or 2 months, it's not going to work. So I tend to switch even after there is absolutely no response on injection 1. I also encounter that in few cases there is increase in edema even after the first injection in some cases. So I see that I tend to change
definitely.
like after one. So
Definitely. Another thing which I had mentioned in this talk is that of the late responders. So we can miss those late responders if we switch too early.
Yeah, too early.
That
That's
also
the
is a
point
problem.
which you need to understand. So most of them they say is, you as per the literature, though you need to wait for 6 months. So the many of them now what they're saying is, even after the 6 months you need to continue them. So we really don't know whether they see, most of the time we call them after a month, whether there's a delayed response or whether the late response is something which we are missing. So 2 months is too early to switch.
Problem is that we treat this as an ARMD. We think that it is age-related macular degeneration. The 3 dose
Absolutely,
and
I
then
agree.
PRN
But
is what.
sometimes even before the patient, I think we get apprehensive.
That's
The sir want to.
Yeah.
Yes.
How
Yeah.
do we define acute and chronic diabetic macular edema, and how do we know if the patient comes to us at the first consultation in a state of chronic diabetic macular edema?
No, that's what, sir. There's one is the, as Saurabh mentioned, one is the visual acuity and the duration.
Okay.
And based on these investigations, you can definitely make out with the pattern of edema.
Okay.
Based on that, you can make out whether the disease is very chronic or not.
Okay.
So, based on these things, you can decide what is your treatment modalities, whether the patient is presenting in an acute phase or a chronic phase.
Okay.
Okay. Thank you, Namit. Now, I'd like to invite Dr. Karthik from Karthik Netralaya, Bangalore, for his talk on combination therapy in DME. Over to you, Karthik.
Hello. So, very good morning. At the outset, I would like to thank Dr. Manjunath for making me a part of this IC at AIOS2025-GP182-Update. So I'll be speaking on combination therapy for DME, mostly looking at what kind of evidences we have to say whether combination therapy with more than one agent really works or it doesn't. So we are all aware about the multiple ways in which DME is treated, and most of the patients we do offer some form of combination therapy or not. So why do we do that? We anticipate that combination could improve the treatment outcome. It could reduce the load of treatment, the treatment burden. When we see that monotherapy isn't giving us what we anticipate to see, or when the disease itself has more than one pathomechanism which is causing the disease to progress or to persist. So one of the commonest thing that we do in our OPDs is to prescribe an NSAID for a patient with DME. So is NSAID beneficial? So there has been a meta-analysis which has been on the Cochrane database, which shows that as a solitary agent, an NSAID has no benefit in treating patients with diabetic CME. But also, patients who have undergone panretinal photocoagulation, nepafenac or ketorolac, has been does help in stabilizing the visual acuity and preventing a progression in the central macular thickness over a period of time. But please do understand that most of these studies have used nepafenac or ketorolac for a duration of as long as 6 months. 3 times a day, which we hardly do in our practice. So most of our practices, the Nepafenac or the NSAIDs are given for at the max a month or 2 after the laser. So these studies have prescribed topical NSAIDs for a prolonged duration and seen some kind of a benefit. The next interesting thing that I came across was prescription of aqueous suppressants in patients who are undergoing anti-VEGF injection. So the thought is that you reduce the amount of aqueous that is getting produced, you reduce the recycle time of aqueous, and that is known to increase the duration or the longevity of the anti-VEGF within the eye. Now, does this really work? There have been studies, but most of these studies are very short duration studies. Some of them have reported benefits, some of them have reported no benefits. But I think it is something that it is very individualistic. It is not a very common practice for us to prescribe aqueous suppressants for patients who are taking anti-VEGF. But it may be considered in patients who have had vitrectomy and who are not fit to take a steroid implant to try to prolong the effectiveness of the anti-VEGF. What about all the nutritional supplements? Every other day we have people coming us and asking us to prescribe omega-3 fatty acids, vitamin D for patients with diabetic macular edema. So does it really help? Yes, there have been enough studies which have shown that vitamin D supplementation or high quality omega-3 fatty acid supplementation does help. But again, the response is slow. It is not that we start prescribing and we would expect a response like an anti-VEGF in a month. It is a period of 3 years, 4 years that we see some kind of a response. So we may have to persist and prescribe, especially in patients who are having deficiency in these things. Now, laser and intravitreal anti-VEGF injection has been studied extensively. The READ, the RESTORE, the Protocol I all have shown that a combination of anti-VEGF with the laser has a superior outcome as compared to solitary laser treatment. This fact that the DRCR Protocol I showed that 40% had limited response has been mentioned by my previous speakers. So there have been studies to follow this up, whether the whether we should add a drug in these instances or whether we should continue. So it has known that whenever we introduce a dexamethasone implant in these patients, it definitely improves the macular morphology. But unfortunately, it has not been shown to have any superior effect in terms of visual acuity as compared to anti-VEGF monotherapy. So though the OCTs look better, the patient does not read better or the patient does not see better. Now, so does combining anti-VEGF with steroid really help? Again, there is a Cochrane meta-analysis which has looked into this. And most of the things wherever this combination therapy has been quoted, many of the places the OCTs always look better, but it does not equally reflect in the vision getting any better. The same with a combination with another anti-VEGF like aflibercept and triamcinolone acetonide. Again, the OCTs look better, but the vision is not very good. What about the inflammatory biomarker? I think Dr. Saurabh has mentioned about it. So morphologically, when we see on the OCT if there are HRDs or if there are sensorineural detachments, substituting a steroid in these instances definitely help to make the macula look a lot more better. So there is a significant morphological change, but again, when it comes to visual acuity, unfortunately, the visual acuity between anti-VEGF monotherapy versus a combination therapy with a steroid and an anti-VEGF does not seem to show a significant improvement. However, the combination therapy arm did have an early recovery compared to a monotherapy arm. Refractory DME has been discussed previously. So a substitution or not a substitution, an inclusion of a steroid in these group shows a good response in patients who have had SNDs. But when there is a tractional component developing like an epiretinal membrane or when there is a vitreomacular traction, the response does not seem to be adequate. Now, steroids can also be given in other forms, like we are starting to give suprachoroidal triamcinolone acetonide. We were giving posterior subtenon, so do they really help? So there are studies which has looked at suprachoroidal triamcinolone acetonide in combination with anti-VEGF drug. So most of these studies are short duration studies, but they have definitely shown one thing is that the need or the requirement or the load of anti-VEGF injection has definitely come down when patients whom we are giving suprachoroidal triamcinolone acetonide. Periocular steroids with lasers has been evaluated as one of the DRCR protocol, but it has shown that steroids in combination with laser showed no significant change in visual acuity or CMT between the groups. So when we are treating more than one pathology, so we are treating the PDR component along with the DME component, is there a role for anti-VEGF? Yes, so when we are giving treatment for these, then it would be preferable that we give a combination therapy in these instances in terms of PRP along with an anti-VEGF or a PRP along with a steroid. The thought being that the process of PRP itself is pro-angiogenic, so it releases VEGF which can worsen the diabetic macular edema. So in these instances, a pre-treatment with an anti-VEGF definitely helps. Does combining micropulse laser with anti-VEGF help? So it did not improve the BCV or CMT, but it definitely decreased the load of injection. So somebody who is prescribing or doing micropulse may see themselves giving a lesser number of injections when compared to a person who is not doing it. Targeted PRP has been spoken about by Dr. Manjunath. So earlier were thinking that the peripheral ischemia actually promotes macular edema, both in RVOs and in DMEs. But now this has been proved incorrect. So there is no role for targeted PRP, and PRP is only suggested when there is either a neovascularization or the other high-risk characteristics of a PDR. The other question is, does vitrectomy help in reducing the diabetic macular edema? So this has been in non-tractional diabetic macular edema. So tractional diabetic macular edema is treated with vitrectomy, but in case of non-tractional diabetic macular edema, does vitrectomy help? So there have been studies which have looked into treating chronic recalcitrant diabetic macular edemas with vitrectomy, but most of the studies show that morphologically the OCT looks better, but visually there is not much of a benefit in recalcitrant. But there was always this debate as to we are intervening very late. By the time we intervene, the damage has already happened, so should we intervene earlier? So in the UK, there was a multi-center trial which looked at treatment-naive patients who underwent vitrectomy for diabetic macular edema, which are non-tractional. And the results were quite surprising, and it showed no superiority of the vitrectomy over anti-VEGF injections, even in treatment-naive population. So this was something that was interesting. So to conclude, so there's not much role of topical solitary NSAID treatment in DME, but definitely can be prescribed for post-PRP cases. I'm sorry, post-PRP patients. Monotherapy with anti-VEGF or steroid is superior in terms of visual recovery, though the morphology does improve. Combination therapy with steroid has no evidence that it really helps. Therapies like subthreshold laser, suprachoroidal steroids do help in decreasing the load of anti-VEGF injections, but in terms of visual acuity, both of them fare almost equally well. And vitrectomy has a limited role in the management of non-tractional diabetic macular edema with or without anti-VEGF and steroid. Thank you very much.
Thank you, Dr. Karthik, for such a confusing topic. He made it very interesting. So I just wanted to ask him whether you want to try a combination therapy first, or whether you want to switch the molecule before trying for a combination therapy. Meanwhile, I request Dr. Sripati to prepare for his presentation. Yeah, Dr. Karthik.
So I think it would, I would usually try to switch because steroid and anti-VEGF haven't shown, though the response after the first injection of steroid is really good, but over time I think the repeated anti-VEGF injections do achieve almost a similar kind of effect. And what we are trying to see is how much of vision is improving. Morphologically, the OCTs do look better after we do a combination therapy, but unfortunately the vision doesn't seem to match with that kind of recovery in the OCT scans.
Okay, thank you. Sir?
Yeah, I have been pestered by my medical representative to prescribe Glow Eye since many years, but I have resisted him. So you said we can give supplements for 2 to 3 years, then it may help. So which
It does.
supplement do you recommend?
So what has been studied is one is vitamin D, sir. So
Vitamin
but
D.
there you can look at serum vitamin D titers and then see if you need to supplement in those reasons. The other thing is good quality omega-3 fatty acids is known to help such patients on the longer run. But again, we'll have to consider the cost to treatment because most of these patients are already on very expensive medications for their systemic management. So that is, and again, there may be a duplication of treatment. Many physicians also do prescribe multivitamins, multiminerals to such patients. So that is also something we'll have to look at.
Thank you.
One important point, as Dr. Karthik was mentioning, is nowadays I request my anti-segment surgeons to use these NSIDs, post-cataract surgeries. So at least for 3 to 6 months. So that will definitely, in patients with diabetes, helps in reduce your macular edema as well as reduce your Irwin gas component also. So nothing wrong. Now even you have a very, like you can use OD dosage NSIDs which are available in the market that you can try. Okay. Can request Dr. Sripati Kamath to present his talk on surgery for DME. Is it a holy grail? Over to you, Dr. Sripati.
Good morning, everybody. At the outset, let me thank AIOS as well as the APO and Dr. Manjunath for giving me this opportunity to talk on this particular forum. I'll be talking on the surgical role for treatment of diabetic macular edema, whether vitrectomy is it a holy grail for treatment of patients with recalcitrant diabetic macular edema. Having gone through the entire spectrum of treatment of diabetic macular edema in terms of topical NSAIDs, topical steroids, various anti-VEGF drugs, various intravitreal implants, as well as intravitreal steroids, and various newer anti-VEGFs. Now we need to look into scenarios wherein we may have to consider a role of a surgery for a diabetic macular edema. So the entire spectrum of treatment for the surgical management of a diabetic macular edema would largely depend upon the configuration and the contour of the vitreoretinal interface. Most of the times it is very evident what is the nature of the vitreoretinal interface which we are dealing with. But sometimes we may have to carefully look into the various sections of the scan so as to find out the subtle vitreoretinal interface changes. Identifying these subtle changes most of the times helps in redefining what is called as the recalcitrant diabetic macular edema, which Dr. Manjunath already emphasized. We may miss certain small faint membranes of tangential traction, and we may continue to treat with anti-VEGF drugs, or some of these tractions may become evident with the subsequent treatment. These membranes may become evident. So serial scanning of these particular retina also helps in identifying what is called as a recalcitrant diabetic macular edema. Various types of vitreomacular tractions have been defined. The most evident ones are the Gullwing type of attraction, where when you have a pinpoint kind of attraction, relieving these are very fancy tractions. Relieving those tractions immediately helps in relieving the macular edema, at least structurally. Functionally may take some time for it to improve. However, there are certain other areas wherein you can see a tangential taut membrane or stretching across the entire posterior pole, including from the disc up till the entire temporal macula, which may be a membrane or a thickened posterior hyaloid also. So relieving these kind of membranes also gives a very gratifying result in structurally treating these diabetic macular edema. Apart from there being a traction, sometimes there can be an abnormal adhesion itself with the pinpoint areas of traction, which can also be well defined with the serial scans of an OCT. Sometimes you may see certain tractions only in the macular, it may be devoid of traction at the macular area or the foveal area, but the traction may be extending up till the optic disc. There may be a vitreopapillary traction, which over a period of time may involve the central area or the macular area, and then the vitreomacular traction may become more defined. So you may also have to look into the areas in the peripapillary area to define the tractions. So predominantly when you see a role of vitrectomy, we see the role of vitrectomy only in a case of a tractional diabetic macular edema, when there are definite membranes or when there are occult surface retinal membranes to identify whether they cause a traction there or not. But however, there are certain set of patients wherein even the tractional, so-called the tractional diabetic macular edema patients also do improve with an anti-VEGF injection despite there being a presence of traction. This was an accidental patient wherein this patient received an anti-VEGF though there being a presence of a membrane, and his diabetic macular edema as well as the visual acuity improved despite there being a presence of a tractional membrane. So sometimes it can be the other way also. Even the tractional membranes which are not getting worsened on an injection, it may also improve the edema to an extent. By and large, the entire the definition of recalcitrant comes when there is no traction, when there is a non-tractional diabetic macular edema, whether you do an vitrectomy, whether this helps in diabetic macular edema regression or not. So this is also a very controversial area. What does this peeling of the membrane, what does the peeling of the internal limiting membrane do to the retina? It improves the oxygenation of the retina. It improves the morphological structure of the retina. It relieves the tractional component definitely. It also prevents the further formation of an epiretinal membrane following any kind of other treatment like lasers or whatever. It prevents the scaffold that is required for a proliferative growth. So if this membrane, we had the opportunity to study this membrane also. So this membrane, when it was sent for a histopathology, we see that these membranes have predominantly excessive collagen or fibronectin, which causes the contractures. So they are abnormal membranes, they are not normal internal limiting membranes, and they generally transdifferentiates into a hyocyte which produces VEGF and causes a macular edema. These are the various proposed hypotheses for the internal limiting membrane peeling helping in diabetic macular edema. So this is a small video which tells us the various techniques which were used. Predominantly whenever we do any vitrectomy for a diabetic macular edema, we use various coloring agents, may in terms of steroid or a brilliant blue or indocyanine green or whatever kind of a dye, so that this delineates the membrane well. Earlier, I never used to use much of coloring agents inside the eye whenever we do a vitrectomy. But these occult membranes which are there stand out very much whenever we do a kind of a chromovitrectomy in terms of either an IVTA or a dye which is being used. Sorry. So predominantly, whenever we peel these membranes in a diabetic macular edema, what we generally see is these are not like a regular internal limiting membranes as we see in a epiretinal membrane or a macular hole surgeries. These membranes are predominantly, they are thick, they are a very different consistency when compared to that of the normal internal limiting membrane. They don't come in one single piece, they are like piecemeal, you know, like we are not able to remove it in one single piece, and repeated staining may be required. Initially we may think that it is a membrane, but predominantly it may be just a vitreoskytic membrane or it may be an epiretinal membrane, it may not be an internal limiting membrane. So unless we remove the internal limiting membrane, we have not achieved the goal here. With the present day membrane instruments like internal limiting Eckart type of forceps, we are able to predominantly remove most of these membranes en masse, the entire membranes. And whenever we remove these membranes, we generally see sometimes there may be a small deroofing of the small inner retinal cysts, wherein we may also see lipid granules on the undersurface of the membrane. That can be sometimes causing what is called as a structural atrophy there. So we may have to be very careful while removing these membranes. This is one such example wherein you have a membrane, a tangential membrane that runs across the disc and the macula, and a dense foveal exudate as Sir described. We generally treat these patients with a group of anti-cholesterol medications also. Fenofibrate has a very excellent role in treating these patients with the dense foveal or subfoveal exudates, which they remain there for a longer period and may cause a kind of a fibrous metaplasia. These instruments like fine kind of an instrument like a scraper, which helps in taking off these particular membranes from the surface of the retina. They are sometimes in a proliferative state. They may also be tentacles which are stuck to the retina. So I would always prefer to do a good amount of peripheral retinal photocoagulation before taking up these patients for diabetic macular edema membrane peelings, because they are just one step behind landing up in a neovascular glaucoma. So basically, to treat their peripheral retina well before we consider removing these particular membranes. So these membranes, once they are removed, again we stain them, so that these are just an epiretinal membrane or a thickened posterior hyaloid scaffold. Once they are removed, we again stain them with the brilliant blue and then peel off the entire membrane, so that gives a very end toto removal of the internal limiting membrane. So we stain them. Once we stain them, then we are very sure that the internal limiting membrane is removed in toto. You see here, the internal limiting membrane is very thick and not easily foldable like regular membranes. They come in piecemeal. They appear to be more adherent to the retina, and you see the entire inner retina basically getting pulled when you are pulling the membrane, as if there is some significant traction there. And when you come across peeling off these membranes at the fovea or in the parafoveal areas, you have to be very, very careful that you don't bring about any kind of deroofing of the smaller cysts, which may cause a kind of an atrophy in these particular areas. So carefully looking into the tractional element in treatment of diabetic macular edema defines it as a surgical case for most of these recalcitrant or non-responding type of a diabetic macular edema. If there are no evident tractions which are seen, always look for subtle tractional component which are not very obvious, and reserving vitrectomy for non-diabetic, non-tractional diabetic macular edema only for certain subset of patients. We may achieve a structural resolution of the edema in most of these cases, but functionally we may not achieve much, particularly when they are non-tractional type of a diabetic macular edema. Thank you for the opportunity.
Dr. Sripati.
So I had one question. So whenever you're treating these DMEs which have tractional, do you, again, without a vascular component, you're not treating the PDR, but predominantly treating the vitreomacular interface disorders, do you pre-treat them with a steroid injection before you go ahead with a vitrectomy, or do you think that has a role in reducing the macular edema and making your surgery a little more uneventful?
Steroid, I generally do not use preoperatively. What I generally do is intraoperatively I use triamcinolone in most of these patients. I deliberately don't remove the peripheral skirt of triamcinolone, which will be used intraoperatively. I strongly believe that this leftover triamcinolone inside the eye will not only help in reducing the diabetic macular edema, also reducing the surgical insult which occurs during intraoperatively. So triamcinolone becomes an integral part of a vitrectomy, and I do not use it preoperatively, but intraoperatively I generally deliberately leave a small skirt of triamcinolone.
I used to do that previously, where I used to inject pre-operative steroid, but nowadays I don't. I've stopped using that. Doesn't make much of a difference surgically and also on the outcome also. Instead of that, intraoperative is better.
Yeah.
Giving a steroid.
And even in not for a diabetic macular edema, like if a diabetic macular edema patients post oil removals also, I generally sometimes use a small amount of triamcinolone to see if there are any membranes left over, and then I leave that triamcinolone at the end of the surgery so that it helps in decreasing the post-operative edemas also.
Thank you, Dr. Sripati. Now I invite Dr. Apurva for her talk on advancing imaging, a contemporary guide for DME management.
Thank
Over
you,
to Apurva.
and sorry for my late entry. I was in another session. Thank you, Dr. Manjunath, for this opportunity. So the first is the oldest, that is Octa. It's a non-invasive modality, detects decorrelation of the OCT signal. We all know about the different vascular plexuses in Octa. So what Octa does is, not only can it qualitatively tell us about the changes in DME, it can tell us subclinical vascular changes, which you may not see clinically or on OCT. It can detect microaneurysms, phase alterations, remodeling, capillary non-perfusion in eyes with clinically detectable retinopathy and sometimes no retinopathy. So this is a phase enlargement, intercapillary spaces between the, that's the capillaries is increased, and here you can see a microaneurysm. It can also map the perfusion, tell us about various vessel densities in different layers, and it has a negative correlation with increasing severity of the DR. So this is an example of how it quantifies the vessel density in each plexus, and it tells us about the intercapillary area. So you can see even in foveal neovascularization, it's so beautifully seen, the phase is beautifully seen. You can make out the flow signal through the vitreoretinal interface. Here you can see that there is advanced neovascularization of the disc and the temporal macula. But fluid interferes with the segmentation. It obscures the anatomical landmarks. Here you can see that when we go through the DME, the cysts, then it becomes all flow voids. And it's important to know that microaneurysms are higher in number in the deep capillary plexus compared to the superficial capillary plexus. Coming to ultra-wide field angiography, it's used in the diagnosis, staging, and management of DR. It detects peripheral NVEs where the posterior pole and the mid-peripheral retina may be normal sometimes. It can help us look at the peripheral vessel leakage, that is late leakage from retinal vessels, and it is seen as hyperfluorescence beyond the vessel walls. This is an example of a 7-field montage, but you can see how much of the retina you can see with a 200-degree field of view. You can calculate the percentage of the ischemia because it's almost like a panretinal view. It can tell you the ischemic index, which is studied to be an independent risk factor for DME. This is how we calculate the ischemic index based on the non-perfusion areas in the macular mid-periphery and the far periphery. Adaptive optics has been around for more than 10 years. Its clinical application has not been very great, mainly because of costs, but it can visualize microcirculation and cone cells at the photoreceptor level. It can tell us about the cell spacing, the cell density, and the cone mosaic structure. So this is an image of a retinal artery. You can see the arterial walls with such clarity. You can see the sheen of the arterial walls. This is an AO fundus photograph. It can be combined with a deformable mirror like a scanning laser ophthalmoscope, an ultra-wide field imaging. So there are many integrations of adaptive optics that has been studied. So whenever you can even superimpose microperimetry on top of the cone mosaic. So there are different things like heterogeneity index. You can see that there are fine structures. This is a hard exudate with hyper and hypofluorescence. You can see hard exudates, these large clumps, and you can see cystic spaces of DME. Increasing irregularity of the cone spacing on AO has correlation with increasing severity of diabetic retinopathy. Of course, it is very logical that there will be decreased cone density in diabetics, and there will be vessel wall changes with decreased vessel diameter, vessel wall thickness, wall to lumen ratio. Coming to the last thing, artificial intelligence in DME, there's a huge role of AI that is coming up with identification of DME and understanding even treatment responses of DME when we use various anti-VEGF agents. So let's look at this graph. Basically, for identification, traditional machine learning based is enough. However, deep learning has been used for both classification, detection, and quantification through segmentation. And understanding treatment responses is mostly deep learn based as well. So what they're saying is, if you teach the machine to detect DME and give it a sample of this particular DME response to this particular agent, it can tell you from a large database whether or not a patient will respond to a particular anti-VEGF. So this is a binary classification framework that separates DME from normals. So this is a little complex, but you can see that it can segment, it can auto-encode. This requires a lot of annotation by manual readers also, but you can see these cystic spaces and fluid which can be segmented very well and very comparable to humans. So this is ground truth where the grader evaluates or marks or annotates the fluid and the cystic spaces, and the segmentation by the machine is very accurate compared to manual graders. So we are also looking into whether AI can detect changes not visible to manual graders, and that is something like retinal layer segmentation and disruption, area exact quantization in terms of nanoliters, which obviously we cannot see, number of hyperreflective dots, optical density ratio, whether there is a difference in the optical density in intraretinal and subretinal fluid, and the classification of anti-VEGF response also, like I said before. And this has improved the efficiency of DME management. Lot of papers in the last 3 years. It has enabled precise customization of therapeutic schedule when the patient should get the next injection, for example, and the probability of whether they'll respond to a particular anti-VEGF treatment. Thank you.
Thank you very much, Dr. Apurva, for that wonderful talk. So how extensively do you use Okta in your management of DMEs? Is it as much as...
Yeah, that's a very good question. In DME, not much, but one application of Okta I found in diabetics was when there's unexplained vision loss, and it is not correlating to the OCT. And you have some parafoveal edema, only evidence is some disruption of the outer layers, but Okta shows very impressive changes when there is phase changes, capillary dropout, and you can attribute very easily, show the patient that this is what is happening in your eye, there's no circulation. So that is a very important application of Okta in my practice.
do you always do an Okta for all your patients before starting anti-VEGF therapy, or not at all?
No. Only when I suspect macular ischemia, because my fluid will interfere with my Okta signals. So fluid is a damper, it will just show flow voids and it should not be interpreted as capillary loss.
Any questions from the audience?
So now, is there any role of FFA in diabetic macular edema?
Definitely. If there is a recalcitrant DME and there are parafoveal cystic changes, and
No,
it's
means compared to Okta, if we have option of Okta.
so you have Okta and FFA, then both of them have very specific indications.
Okay.
OCT is still the modality for the win in DME, but Okta only if suspecting macular ischemia. FFA also helps, but it is invasive. If you want to plan a focal laser, then FFA is the way to go.
Thank you very much. Thank you everybody for attending the session. I thank the speakers and the audience. And we will hand over the hall to the next. I request all the speakers to gather on the stage for a photograph.